I was having a lot of back pain, and my back would just ache. And I had one real sharp spot it felt like there was somebody with a knife inside me pushing it out, and a lot of leg pain. It would keep me from sleeping at night, and it was quite miserable. I already had 2 back surgeries, and I went back to the surgeon who had done the second surgery, and he said, I think we've got to put a screw in your sacroiliac, and I don't like to do that. And it kind of frightened me. And I'd heard wonderful things about Dr. Perez-Cruet, and actually he had done back surgery on my daughter-in-law and 2 of my sons. So I went to see Dr. Perez-Cruet at Michigan Head and Spine Institute.
I'd like to talk to you about one of the patients I've treated, and really exemplifies why we've gone down this road of trying to provide minimally invasive spine surgery treatments for our patient. The key with these minimally invasive spinal treatments is to try to treat a variety of very common pathologies that we see, many of them causing debilitating back pain, in a way that preserves the normal anatomy of the spine, and to really reduce their pain and suffering and subsequent surgeries. So what we're seeing here is a CT myelogram. This patient had had previous surgery done in a very traditional manner. You can see this is the spinous process of the spine. This is essentially the bone that holds the muscles of the spine, and you can see they were removed to take the pressure off of the nerves here, which you can see it's been done well, and there's screws that are put in to achieve what's called a spinal fusion. The issue with doing surgery like this is now an axial cut, and it correlates to where this laminectomy was done. You can see the spinal canal is nice and open, but as we come up further to just above where the surgery was done, you can see where the nerves, and I'll blow this up to make it a little clearer for you. You can see where the nerves become completely pinched off. You see right here, there is a dark spot that represents an extruded disc, and then severe stenosis, and you can see right here where the dye is completely cut off and stopped. So this patient, now after having this extensive surgery with removal of much of the bone here, is really in a tremendous amount of pain because the nerves are essentially being pinched at this area. This is a condition that is not uncommon to this kind of spinal surgery, where we've essentially removed a lot of the normal anatomy of the spine. We've now done an extensive instrumented fusion and instrumentation. And once again, this is one of the reasons why I chose to go into the field of minimally invasive spinal surgery and try to develop technologies and way of treating patients that avoid all this, what we call iatrogenic injury to the normal anatomy.
He felt there was way too much hardware in my back, and he was hoping to remove some of that. But also I had a herniated disc and spinal stenosis, and he showed me where my spine was completely blocked.
In this particular case, what we did was we don't want to mess with the whole hardware. To remove it, that's an extensive operation. We made 2 parasagittal incisions, means that we made an incision here, and we cut with a cutting burr. We cut the rod right there, and we removed this screw, and we did it on the other side as well. So we just removed the top screws right here, the rod and the screws. Then the next step was we came in from the right side, because the disc herniation is on the right, so this is the right side, and we did what's called a minimally invasive laminectomy. Now, a minimally invasive laminectomy is really a wonderful procedure, because the way we do that is we come on the lamina here, we drill it, and then we undercut the lamina right here. So we are actually preserving the spinous process. So we did an ipsilateral laminectomy, undercut the spinous process, contralateral laminectomy. That opens up this spinal canal. We then take the ligamentum flavum off on the right and then on the left. And once we did that, we provided a lot more room for us to work. Then we went to the side where the disc herniation is. You can see it right here. And we took off some of the joint, the facet it's called, to carefully remove that. This is a very dangerous level to operate on. 5, 4, 3, 2, 1, because it is a level of the conus medullaris. And so that's a very sensitive structure, and this patient can easily wake up with what's called a cauda equina syndrome, where they can't control their bowel and bladder, especially with that level of stenosis. So we remove that disc, and because we removed enough bone, we don't want to have problems between these two vertebrae. So then we put the bone that we removed, that we collect, into the joints, called a Fassett posterior lateral fusion. Essentially, we put it right into that joint space right here, there, and there. So we do a posterior lateral fusion and then put new screws up here above and use the old holes to put in new screws on that level and then span that with a very short segment. It's a complex case that I don't think would have been necessary had she had a focal treatment of this spondylolisthesis, just with a focal operation.
I'm 4 weeks out of surgery, and I feel like I'm doing very well. I know the home nurse said to me, I've not seen a back patient do as well as you. My legs don't hurt, and my back, once I'm up for a few minutes, I do feel quite good. I love downhill skiing. Just absolutely love it. I'm hoping that when I get healed up from this back surgery, I'm looking forward to getting back on my downhill skis. I've been a church organist since I was 16, and I usually play every day. I'm very pleased with my progress and hopeful to get back on my skis.